Hello medicos. Today we're gonna see the topic of DKA, which is the concise presentation now. In this topic, we're gonna see about introduction, etiopathogenesis, clinical features and signs, investigations and management. So what is diabetic ketoacidosis? It's a serious complication of diabetes that occurs when the body produces high levels of blood acids called ketones. It is characterized by hyperglycemia, ketosis and metabolic acidosis. So it occurs due to the absolute or relative insulin deficiency combined with increased counter-regulatory hormones such as glucagon, catecholamines, cortisol and growth hormone. So whenever you are taking a case history, you should ask about the features of diabetes mellitus like polyuria, polydipsia, polyphagia, and you also ask about the treatment history and follow-up history of the diabetes mellitus, and you should also ask about the infection history like pneumonia. The pneumonia histories are include cough, sputum production and chest pain. All those things you have to rule out. And you should also ask about UTI, which is common infection. So in that we have to ask about burning maturation, such that you have to rule out some infection histories also. And most commonly, the diabetic ketoacidosis is also common in pregnancy and drug abuse. So you have to ask about the histories of drug abuse and pregnancy history too. Next, regarding physical examination, you have to rule out the signs of dehydration, since diabetic ketoacidosis is associated with dehydration. And you should also ask about tachypnea, and you should also ask about tender abdomen. Next, talking about the etiology. The etiologies includes infections like pneumonia, UTI, and all those things, and omission of insulin therapy, which causes increased diabetes, increased blood glucose level more than 250 milligram per deciliter. Then that condition causes diabetic ketoacidosis. And also new onset of diabetes mellitus, most commonly type 1 diabetes mellitus. In that case, the beta cell destruction do happen, so that the diabetic ketoacidosis will occur. Next, also in the case of surgery, in the case of trauma, in the case of myocardial infarction, it is also most common. In the case of stroke, and certain medications like corticosteroids and thiazide will also cause the diabetic ketoacidosis. Next, regarding the clinical feature, how those clinical features are developed in the diabetic ketoacidosis, we will gonna see now. So in that, first there is decreased level of insulin. The decreased level of insulin causes increased blood glucose level more than 250 milligram per deciliter. So this increased blood glucose level more than 250 milligram per deciliter will cause activation of counter-regulatory mechanism. This activation of counter-regulatory mechanism is nothing but increased levels of glucagon and corticosteroids. This increased level of glucagon and corticosteroids causes more lipolysis and more gluconeogenesis and more glycogenolysis. So this is more gluconeogenesis and more glycogenolysis increases the level of glucose, and it causes signs of dehydration. Because the glucose levels are increased, means what happens, the water will also come out due to osmotic difference, and that causes signs of dehydration such as loss of skin turgor, dryness of mouth and polydipsia. And also I told more lipolysis. This more lipolysis will cause more fatty acid oxidation. This more fatty acid oxidation will cause more ketone body production, and this more ketone body production will trigger chemotactic CTZ in the brain, and that causes nausea and vomiting. And this ketone body will also increase urination, and that cause potassium loss, and that leads to tender abdomen. And due to the accumulation of more ketone body, what happens is there will be decreased pH. So this decreased pH will also leads to increased ventilation, and that causes tachypnea. So these are the features regarding pathogenesis. Once again, the decreased level of insulin causes increased blood glucose level that is more than 250 milligram per deciliter, that causes the activation of counter-regulatory mechanism that increases the level of glucagon and corticosteroids. So more gluconeogenesis and more glycogenolysis do happen, that causes signs of dehydration, and there is more lipolysis that causes more ketone body production that leads to nausea, vomiting, and more ketone bodies is also causing hypokalemia that causes tender abdomen, and more ketone body that leads to decreased pH, and that causes increased ventilation, and that leads to tachypnea. Talking about the clinical features, include all the features of diabetes mellitus such as polyuria, polydipsia, polyphagia, and it also includes the features regarding tender abdomen, and it also causes tachypnea. That tachypnea includes Cosmos breathing, that is fruity order breathing, and that causes altered mental status and altered mental sensorium, and it also leads to signs of dehydration. It also causes nausea and vomiting, as I said in the previous slide. So what are the investigations you should do regarding diabetic ketoacidosis? It includes analysis of serum blood glucose level. Since the serum blood glucose level more than 250 mg per deciliter is the causal agent of the diabetic ketoacidosis, and the total treatment aim is to bring the glucose level to 150 to 200 mg per deciliter. So our main goal is not to reduce the blood glucose level completely. Our main goal is to reduce 150 to 200 mg per deciliter of glucose only. Next, whenever we analyze the arterial blood gas, the pH should be less than 7.3 and PHCO3 should be 18, less than 18 means that is the investigation regarding the diabetic ketoacidosis. And you should also check serum electrolytes, since potassium levels will be more prone to decrease in the diabetic ketoacidosis. And you should also check about urea and creatinine levels, since serum urea and serum creatinine levels are important to analyze the acute kidney injury. Next, you should also rule out serum amylase and serum lipase levels, since in DKA serum amylase levels will increase. And to rule out other conditions, you should also check with CT abdomen and ECG. How do you manage? We will manage regarding replacing the fluids. The fluids will be replaced by using normal saline, 2 to 3 liters of 0.9% of normal saline for 1 to 3 hours you will give. On progression of the treatment, if the blood glucose levels is less than 250 mg per deciliter, then you should use dextrose normal saline. And on progression of treatment, if serum sodium levels are increasing, then use N/2 NS. Regarding insulin therapy, you should first monitor the serum potassium level. If the potassium levels are less than 3.2 milliequivalents per deciliter, you should not start insulin. Whereas if the serum potassium level are more than 3.2 milliequivalents per liter, you can give insulin bolus. IV insulin bolus 0.1 international unit per kg, followed by IV insulin infusion 0.1 international unit per kg per hour. If serum potassium levels are less than 3.2 milliequivalents per liter, as I said, you should not give insulin. You should first correct the potassium level by giving potassium chloride. You should also correct the metabolic acidosis by giving the sodium bicarbonate. So that ends up the diabetic ketoacidosis. Thank you for watching.